Thanks for coming tonight. My name is Scott Sauer. I'm an orthopedic surgeon, board certified, but I'm fellowship trained in foot and ankle. And my experience in general has been with foot and ankle orthopedics, but along those lines I've come to take care of dancers throughout my career at this point, and be it ballet or jazz, Broadway, even Irish dancers. I actually have a close friend that his wife was a world champion Irish dancer when we were in college. So, you know, I've managed her a little bit and just gotten some experience in doing that. And that's kind of how you do things. You get a lot of experience when one person knows that you take care of dancers. That's kind of what happens. So, I thought this was a relevant topic, even though it's pretty individualized and specialized, but, you know, not a lot of people know what to do with dancers, especially if they have an injury. So I wanted to just touch on a few things. I know our ad said the top 5 injuries, but I'm going to do a little bonus tonight. It's going to be 10 injuries that I figured, you know, why not? You know, we got the time. So, again, I'm an orthopedic foot and ankle specialist, so that's what I do. So when we talk about dancers' feet, I mean, it's a very unique structure. It's what we call slightly cavus, which means there's a high rounded arch, and this is, you know, more apt for ballet, but it can be for any foot in general. A high arched foot. The metatarsals typically are thickened for the demi-point position, which is really when you're putting all the weight under the pad of your foot. And that, you know, has to be that way just from years of training. And often you get calluses, which, you know, accommodate the pressures on the bottom of the foot. There's also narrowing of the metatarsal, so that basically means the foot is sort of narrowed, which is helpful depending on the foot type you have. You certainly don't have to have a narrow foot to dance, but in general, for ballet, when you're putting your foot into a shoe that requires that, it's helpful, and the toes are often straightened to accommodate the toe shoe. And then, of course, the extreme range of motion that's developed over years. And, you know, even though at a young age you may be fairly loose ligamentously, it really, you know, as you're progressing through your career, obviously that's important to have that range of motion. And then in terms of shoe wear, particularly for ballet and Broadway dancers, wear any, you know, one of these shoes. The toe shoes, which are, you know, when you're on full point, it's a, you know, typically a hardened toe box. I'm not entirely sure the exact material, but cardboard, I'm sure there may be fiberglass. There are so many different hardened materials now that try to make the shoe lighter and everything. The ballet slippers are soft and glove-like, and I'm sure everyone knows what they look like. The character shoes are typically, like for a Broadway show or something, they have a specific role in any form of dance, and they may be flat or have a small heel on the shoe. Actually, I have some pictures of those. And then jazz shoes, which are typically a softer shoe, and they have a small heel that can be used in jazz or Broadway dancing. Then there's Irish dance, which I touch upon just because I have some patients that are Irish dancers, but these, they have a soft shoe, which is what you see here on the left, and then a hard shoe, which it almost looks like a Frankenstein shoe because it has to be really rigid when they do their hard shoe dancing to make you know, various movements and sounds and things as they're doing the particular techniques. So some of the conditions that the conditions I'm going to talk about tonight are these. The typical conditions are probably the more common injuries or conditions that dancers will have: toe fractures, bunions, hallux, rigidus. We'll talk a little, you know, get more specific on what these things exactly are and how some of the ways I treat these, whether conservatively or surgically, and just the options that are available. Mark, who I hope to talk with about some of these things, maybe at the end, he's going to maybe talk a little bit about how he treats the dancer patient and how he focuses on the problem that they're sent to him for, but also just in general their whole biomechanical state when they come to see him. So again, to go down the list: sesamoid injuries, metatarsal fractures, ankle impingement, ankle sprains, Achilles problems, heel pain, and shin pain. That's a lot, but we're not going to spend too much time. I just want to describe what these things are, what you can look for, and how they may be treated. So the easy one is, toe fractures. We have, what typically happens. They're pretty common in dancing, but typically they don't happen when you're dancing. They usually happen when, you get up in the middle of the night, you hit your foot on something. I mean, that's how everybody breaks their toe. You get out of the beach chair, you get your foot caught in the pool. But, it can definitely happen in dancing. And in modern dance, if you're not wearing shoes, you have to be careful with that. And the soft shoe type apparatus that you wear, you're at risk. So that's usually what happened. And the majority of these can be treated conservatively, but this may be what you see. You have on the picture on the left, the fifth toe or the outer toe is obviously angulated funny. That's a broken toe. You can reduce that and put it back into place. Pretty straightforward. And then it just involves some taping like you see on the bottom right. Taping the toe and activity modification until the pain resolves, which often is before the fracture heals. But depending on the type of dance and what's coming in the future, I treat a dancer. I think a dancer is probably one of the more rigorous athletic, things that you can do. So just like I treat my athletes in season, I'm going to do my best to get them back to whatever they want to do. And if they're pain-free and we could tape it or do something to kind of get them through whatever the recital is or the program, then I'll do that. So this is a pretty standard treatment. Rarely does it need surgery, but like in that upper right picture there, sometimes the fracture is an unstable fracture, typically at this the first toe area where the hallux or the big toe. That's a very important toe, particularly in dancing. So if there's an unstable fracture, that might require some kind of surgical intervention. But the lesser toes or the smaller toes typically don't require something to be done. Bunions, we've seen bunions. They're not only prevalent in society, they're also prevalent in dancers. And basically a bunion is what this picture shows. The big toe deviates towards the outside of the foot. There's stretching of the inner part of the big toe at the knuckle area, and a bony bump forms. Either that's from the bone, the first metatarsal bone, or an extra sort of bony bump develops over time. And this is a problem not only in dancers but also in just society in general, typically with shoe wear. But it can be devastating to a dancer just in the sense that it can be painful, limited range of motion occurs with a bunion, and that's a problem, obviously. However, they're no more common in dancers than any other group of female patients. I think that's a misconception, is that you think because you dance you develop a bunion, but that's not necessarily the case. There is a genetic predisposition to bunions, depending on your foot type. Most people see their parents' feet or a relative's foot, and this is the kind of foot they have. Well, they may or may not develop bunions. It's also environmental in the sense with shoe wear, women's shoes are typically narrow and pointed, and just with years of wearing those shoes, plus genetically having a foot that may be a little bit wider, can predispose you to a bunion. So people are either going to get a bunion or they're not. If you have a foot that isn't prone to getting a bunion, then even as a dancer you may not get a bunion. Although there is extra stress on the foot, it really comes down to the foot type. And the other consideration with bunions is they need really a pretty extreme range of motion, 90 to 100 degrees of dorsiflexion in the first metatarsal phalangeal joint. So that's where the big toe meets the foot. And this picture kind of shows that, the inner foot there, this area is about 90 degrees or more. And that's right here where the big toe meets the foot. It has to get that way. And if it can't because of a bunion or what we're going to talk about next, then that's a problem. The things that can change range of motion are bad for dancers. So just having a bunion may be bad because your range of motion may not be there to do particular dance like ballet. You could certainly do other dances or other types of dance, although it still can be pretty painful. But the other thing that can affect range of motion is surgery. So bunions don't correct themselves. They typically need to be corrected. You can manage a bunion, you can try to alleviate symptoms via shoe wear that is wider or an accommodative toe box. Sometimes some bracing or toe spacers can take effect, but you're not curing the bunion. Really, the only way to get rid of a bunion is through surgery. Unfortunately for dancers, that can be devastating and can be career-ending because now you're creating scar tissue in the area. Even though you're correcting the bunion and the foot may look nice, you'll lose range of motion. There's always stiffness associated with it that you can, like a person that doesn't dance may be able to tolerate that very well and they get back to running and doing things. It's just the extreme range of motion that's needed with dancing is significant. So typically surgery for bunions in serious dancers is deferred until they're ready for it or they just can't tolerate it anymore or they're ready to risk ending their career. And we'll often manage the bunion with something like this, which is a toe spacer. You have to be careful because now you're jamming a lot of stuff in the shoe and you're making the shoe even more constricting. That can cause more pain. So this may be temporary. It may alleviate some symptoms just with normal activity, but in terms of dancing, it can be definitely be difficult. Hallux rigidus. Now this is a condition that's a pre-arthritic type of condition. And what happens is because the toe is flexed so much and extended up, like in the top picture, that over time you can develop a range of motion that is limited just from some arthritic change that develops. You get a bump that develops on top of the foot, which is that bottom picture there. You can get some spurring, and that will limit the flexion of the toe, or the dorsiflexion we call it, or pushing the toe straight up. And that is significant, and that affects dancers significantly. You lose the dorsiflexion. It could prevent getting into demi-point properly, and actually can force the dancer into a different position, which they call sickling, which basically means you're not getting on the inner part of your foot, but you're now rolling out to the outer part of your foot, and that has biomechanical problems that can occur over time. Not only is it a poor technique, but it also can affect just pretty much everything in your lower body based on the way this is. But you can see why it happens, because this person here could not effectively flex their toe up. They have to roll out to the side to accommodate that position, and that's not ideal for ballet, certainly, but even in general for other forms. So the treatment for hallux rigidus really is, again, you can try to manage it conservatively, and it's trying to do things to limit the movement of that toe without affecting technique or activity. It's easy to do in athletes and other forms of sport. It's hard to do in ballet because they require extreme range of motion. Other forms of dance, you can effectively limit the movement to try to limit pain, but it can affect ultimately the dance. Surgical considerations in this are actually favorable, because if it's just a simple spur that's developed or some early arthritis, you can safely go in to that area and remove all of the spurs off around the toe and around this joint and loosen the joint up, if you will. You can clean out the debris and get rid of the spurs that are blocking movement. And then after that's completed and everything heals, which is usually over about 10 days in terms of incisional healing, then you start a rigorous program to try to improve range of motion as soon as possible. It's not advised to limit the movement of that area after surgery, because you want to get the movement back as soon as possible. So surgery consideration in hallux rigidus is favorable because you're trying to improve range of motion. Okay. The sesamoids. So what are sesamoids? Classically a sesamoid bone is an extra bone. It's a bone that is encased in a tendon, some type of tendon. And that can be any bone in the body. Your kneecap is like a sesamoid bone because it's encased in the thigh muscle, and it goes down into the tendon of the below. There's a tendon below the kneecap that attaches to the tibia. Well, that's a separate bone encased in tendon. Well, you have sesamoid bones in your foot, and they're right underneath the big toe at the knuckle, and they're encased in a flexor tendon that helps to pull the toe downward. So they're directly underneath that area in between the fat pad and the pad of your foot that hits the floor. So they help biomechanically to make the pull on the toe more efficient, and to get your toe down as much as possible. It helps to diminish friction in that area because they do articulate with the head of the first metatarsal. This is just an x-ray of that. So now we're looking directly at the metatarsal on end, and these two bones are below it, right between the skin and the bone. So when you walk, you walk on the sesamoid area, typically. They modify pressure in the area, they disperse it over the area more. And most people don't even know they have sesamoids. They just assume it's an injury that they can work through, and they push through it. And actually, typically dancers will ignore it, and then I'll see them when their career is over, and you get an x-ray of their foot, and their sesamoids they're almost like dust. They're just smashed because they just have ignored the sesamoid problem, and they're even though they may not have pain anymore from dancing, but their sesamoids are not. They don't look nice and round like they should. And that can affect later in life the way your toes move and things like that. So what can you have with a sesamoid? I mean, you can have simple inflammation of the sesamoid. And here's another view of where the sesamoid is in your toe. Sesamoiditis is more inflammation around the sesamoid or even inside of the sesamoid bone. You can just beat it up so much that it gets inflamed in the bone. You can fracture the sesamoid. Basically, just from the repetitive pounding. It's like getting a stress fracture, hitting the bone enough that it would actually crack in half. Ligament injury can occur around the sesamoid. So ligaments are what hold bone to bone, that hold any joint, and they basically can get injured and irritated just from these extreme ranges of motion that occur. And then there's something called avascular necrosis, which can occur, and that basically means that the blood supply to the sesamoid has been disrupted, either from a direct injury or just from the repetitive overload on that area. Over time, that bone can actually die. The blood supply is cut off, the bone dies, and that can cause pain, or it can fracture because of that. And that's a problem that can be significant with dancers, particularly if they have to get their foot in this type of position. Treatment for sesamoid injuries, depending on which type of injury it is. If it's a mild sesamoiditis or an inflammation, you can treat that conservatively. Sometimes you put some special padding in a shoe, you can tape the foot, you can do things to try to get the pressure off of that area directly, and alter a shoe. If it's a ballet shoe or another type of shoe, you can put something in the shoe to take the pressure directly off that area and let things settle down. Whereas for other types of injuries, they may require more conservative or even surgical considerations. If there's a fracture, avascular necrosis, a lot of times you'll immobilize for a period of time just like any other fracture, you would immobilize it, allow it to heal, and then you would go into a weight-bearing portion or do some therapy to try to get things moving. There are surgical considerations and successful in dancing, but you have to be very careful because once you remove, there are two sesamoids. If you remove one, you can destabilize the area, and it can be a problem later. You're also now committing to a fair amount of rehabilitation after a surgery. So you're talking about 3 to 6 months of limited activity, and certainly not the rigors of a dance. Metatarsal stress fractures. The most common one in dancers is the one at the base of the second metatarsal. So if we look at these pictures, the big toe, or the inner part of the foot, is where this metatarsal is. That's the first metatarsal. So on this side it's reversed. But the second metatarsal, when it comes to the middle part of the foot, is a very common area to get a stress fracture. And that's just because of the way the foot is positioned and it hits the ground. The forces generate through that area pretty extensively. And whereas the first metatarsal may be a little bit more mobile, it's also stronger, and the second isn't as strong. It's also, if you look at this, you can appreciate it. I know it's hard, but it's almost encased and surrounded by the other bones. So this area is really immobile, and it stays there, so it doesn't have a lot of flexibility, and their extra stress is transmitted through that bone, and that's why you can get extra stress in that area and get a fracture. So that's a common fracture that dancers can experience. It's not common in the sense that they get it, every dancer gets one, but we look at that pretty exclusively if they are a dancer. Another type of dancer is actually called the dancer's fracture, but this is more of an acute injury, meaning not an overload, repetitive nature, but like when you invert your ankle, if you're coming down off of a jump, typically if you're going to fracture something in the metatarsals, it's going to be in the fifth metatarsal. So now we're talking about the outer metatarsal in the foot, and this is an acute injury that occurs. And it's a metatarsal shaft fracture. So the shaft of the metatarsal is right here, as opposed to the head or the base. And you get an injury like this, where the metatarsal breaks. It's a twisting kind of injury, and it breaks in half. Now, the majority of these, if they're non-displaced, can be treated conservatively. So just like an A fracture, you may put them in a cast or a boot, depending on what it looks like and the time from injury. But that picture on the left is moderately displaced. I mean, it's not perfectly aligned, and you can appreciate it doesn't look like the other metatarsals. So there are surgical indications to fix these types of fractures. You put them back together, hold them there with plate and screws, and so they don't move, they heal, and then typically with a fracture that's healed, you can get back to normal activity. So it's not a career-ending injury for a dancer to have a fracture like that. So based on what we've talked about so far, are there any questions about anything?
On that dancer's fracture, is there
Yes.
going to be just pain? Because I've seen each of these things over the years. Some things present with swelling and all more of strained sprains, whereas these, there really wasn't a lot of discoloration or swelling.
Mm-hmm.
It was more pain with weight bearing
Mm-hmm.
or certain positions.
Yeah.
And I'd say, you better get that checked out because it could be a fracture.
Right.
Am I in the right ballpark? with
Yes.
that?
I mean, you have people that have exquisite pain with an acute fracture. Other people that have a stress fracture, one that's not occurring immediately, may have just a gradual onset of pain, very limited in the beginning, and then over time it just gets worse and worse. And you know dancers better than I do. I mean, they don't want to stop dancing, so they'll accept all kinds of pain and just live with it until they absolutely can't do it anymore. And I can understand that mentality, but oftentimes things can be avoided if they're just sort of looked at early, and you can do things. And I think, when I see somebody like that, I'm always like, I wish you would have come to me sooner, because there are things that can be changed, can be looked at on technique and just biomechanically. And Mark he's an advocate of this too, and he'll touch on that a little bit. Just in general, how somebody functions, and muscles that you think are super strong in dancers really aren't that strong, and you may think you're strong, but you may be strong in some areas but not in others. Okay. So yeah, you're right to assume, it's better to be conservative and have it looked at early than later. But if you don't see it until later, I mean, it can present with just swelling, it can present with pain, it can present with discoloration and no pain. So there's a lot of ways you can look at it. And some patients have medical problems that you don't necessarily know about. So you may not, maybe they don't feel as well, now I'm not saying that young people have diabetes that maybe have neuropathy, but that's a little unusual. But some people can have things that maybe they don't feel pain as well. So you just have to look at that. So the next topic, anterior ankle impingement. Basically, so now we're up in the ankle area, and with with dancers, some specific types of ankle problems they develop. One is impingement. You can have it in the front of the ankle, you can have it in the back of the ankle. So in the front of the ankle, it's very common because what happens when they do jumping and leaping, you land on the front part of your foot, and your foot has to really hyper extend. And over time, if we look at this x-ray, this is the front part of the foot, and here's the ankle joint, you can see that this should be nice and flat here, but there's like this little hook that's developed over time, and the bones can hit each other in the front, and that really limits your dorsiflexion or bringing your foot and your ankle up, which may be fine for people that do normal walking and running and other sports, but when you need extreme range of motion, just like with the toe, the ankle can be severely limited with this. So what happens is you assume that, well, I can't get my ankle moving forward or up because my Achilles is tight. So that's in the back of your ankle, and you spend hours and hours trying to stretch your Achilles, but you're not getting anywhere. And this may be what's happening. You can get a bony block in the front of the ankle. Sometimes there's inflammation in the front of the ankle that can cause pain when you bring the foot up or you're bending the ankle up. And that, can be mistaken for, problems in the back of the ankle, which would be like an Achilles. It's pretty rare that dancers have tight Achilles. I mean, it just doesn't really happen. This is often something that can happen, especially the accomplished dancers. I mean, you know what you have to do to maintain your flexibility, and that's what happens. So in this case, it is more common in male dancers only because they're doing a lot of leaping and jumping, and on Broadway, they might be doing tumbling and things. So you have to, with the extreme dorsiflexion, this can occur. Now, what in some cases you can add things to their shoes. It's a little bit harder in ballet, but just putting a simple heel lift in the shoe now drops the front of the ankle down, and it opens up the front more. So there's not as much impingement as the ankle comes up. So that's a simple way to deal with it. Surgically, you can go in there arthroscopically, so use a little camera just like you do an arthroscopic knee procedure, and you can actually remove that spur if it's there. And it's a pretty minimally invasive thing. You go in, you clean it out, and that actually helps a lot for people to gain more range of motion and decreasing pain.
So that's from overuse? Actually grows?
It can, yeah. It was believed to be a traction injury of the ligaments around the ankle, but it's more from the repetitive trauma of the area, and you get bleeding in there that can occur, that can cause that to form. That takes us to the back of the ankle. Things like posterior ankle impingement. I think Mark, it was an excellent point. He brought up the fact that even just the mild or a less a severe case, may be due to just having some capsular tightness just from various injuries that you just sort of live with, and it happens. My ankle hurts, but now it's better. But that creates scar tissue, and that can definitely affect movement. So when we're looking at something like this, the posterior ankle impingement, that means the back of the ankle. Basically, when you're examining dancer, this is typically what you would find, and then you have this particular X-ray, which I thought was really interesting. The two arrows are fortunate, and you can see now with this posterior part back here, there's not a lot of space there, so the tibia bone is actually almost hitting the calcaneus or the heel bone. Well, there's not just empty space between those structures. There's ligaments, there's fat, there's tendons that are back there. So, over the years of training or even, less than that, those structures are going to get beat up, and that can get inflamed, and you might get pain in there. There's also something called venous trigonum, which it's hard to appreciate, but there's a little circular density there that can develop just from birth. It just doesn't fuse to the talus bone, which is this part of the ankle here, this talus bone. So that area there can be irritated, and it pulls off the bone a little bit, or it'll get inflamed and it gets pinched. So that's a reason you can get posterior impingement. That's something that can be managed conservatively. Sometimes it requires mobilization, flexibility, some therapy to get things moving, or you can go in surgically and extract if necessary, if it's even there, if there's something blocking it physically, or there are other modalities to try too. The other thing that you can see too is, this rigid formation or structure as it, goes up. The forces are generated through this area, and that's when you get into trouble in the front here. That's where you can see that with these forces transmitted so strongly through that area, that's how you develop the stress fractures, and you develop, other foot and ankle pain just because of the extreme forces that are generated. So those are two ankle conditions I think are concerning. I think that people may not recognize or understand, and I think it's helpful to know a little bit about that. Certainly, we don't have to talk about ankle sprains too much. They're probably the most common injury in orthopedics, and certainly in dance, just with the amount of movement and jumping and leaping that is done in any form of dance. Typically, this is what you see, the inversion injury, where you'll tear ligaments, the outer ligaments of the lateral ligaments are torn. Almost to a T, always can be treated conservatively. Unless, of course, you have multiple ankle injuries, and you may develop instability because the ankle ligaments aren't necessarily healed appropriately. Sometimes you need them to heal really tightly, and they don't, and just from having multiple injuries. So in those cases, you can consider going in and tightening them up or reconstructing them. Again, that might be something though that affects a career, because now you're messing with ranges of motion and just strength and things like that, and you develop scar tissue. So conservative treatment, and certainly Mark's the expert on this, but I just thought it was important to focus on something you may not even think about, which is like the peroneals, because as the peroneal tendons are on the outside of your ankle, they course right behind the fibula bone, which is that knobby bone on the outside. Well, when you sprain your ankle and you invert it like this, the peroneals are also affected. They're stretched, they're strained, sometimes they're even torn. And unfortunately, when you don't have ligaments that are now supporting the ankle, the peroneals take an even larger role. And if they're injured, now you have these tendon structures that are trying to move the foot, and they're also now trying to stabilize the ankle, and they basically are under a lot of stress. So that's a very important part. Certainly not the only thing to focus on, but it's very important in terms of dance, because that's a significant force generator for dance. Do you have any comments on that, Mark, or do you want to wait? I think for sprains, I think you can talk about that. A few more slides. The Achilles tendon is an issue, can be an issue. Now, I bring it up because it's the largest tendon in the body. Also, when you're talking about running and jumping, it can generate up to 4 to 6 times the body weight is sort of pushed through this big tendon, and that's significant. So you can develop a tendonitis, or you can develop a tear based on the amount of repetition you're doing, the force that goes through it, or even in general having bad technique or questionable technique. So this is just a picture of what a tendonitis is. Basically, inflammation of the tendon develops over time. You may have micro tears in the tendon that cause it to get inflamed. Versus a complete tear, or shows a partial tear. I mean, that can happen acutely, just based on the way a foot hits the ground, or the forces that are generated very quickly and eccentrically. Or it can develop over time. If there's a tendonitis in that tendon already, it can tear. So you have to kind of pay attention to that. You would typically see, swelling, pain over the Achilles. I mean, that's the most common. The ones that rupture acutely, they may feel like somebody hit them in the back of the leg with like a stick or something, or they thought somebody hit them or something, but that's just the tendon tearing. And a lot of times they may not have any pain after the tear, because once the tendon is torn, the nerve endings in the tendon there aren't many nerve endings there for pain. They may get pain from the swelling and the bleeding that occurs after, but I've seen people walk into the office a week after an Achilles tear, and they just have weakness in their leg that they can't go up and down stairs. So it's not unusual not to have pain, but the chronic tendonitis can have pain, and that given the activities that are being done, it's a little bit unusual in younger patients, but you get into the older teenagers and stuff, they certainly can develop a tendonitis. Again, can be treated conservatively, typically is treated conservatively. In rare cases would you go in there surgically, unless there's a big tendinotic defect or something in the tendon that just can't support the body weight. And these are some things that I think, I don't have a lot of experience with these particular devices, but I know that these are being utilized in studios just to improve Achilles' range of motion, and there are various and many different ways to do that. I think these are just a couple examples. The block on the left, but then in the right, they've tried to establish these shoes that maybe either are strapped differently and don't push directly on the area that's inflamed, or can cushion it somehow so that there's not a lot of pressure there. Is that something that you've
They make
seen?
ribbons now that have elastic pre-sewn, so that it's ideally supposed to go right around the tendon, so that when there's pleating, there's not as much stress from the ribbon. So
Right.
there's actually an elastic there.
Yeah, right. That's interesting. And do you find that it works? Have you ever seen it?
Mm-hmm.
Yeah, I mean, I think it's a good idea. Certainly, compared to a rigid, thick ribbon there, constantly
Well, you
rubbing
think
on the
about
area.
how tight we
And
tie it,
right.
and then you're pleating, and then there's that stress, and you just keep going. I mean,
Right.
so, yeah.
Yeah. Heel pain, again, another concern. Many causes. Plantar fasciitis is a cause. So there's a thick strap of tissue on the bottom of the foot called the plantar fascia, very instrumental in making the foot flex, in particular, in various movements. You can develop an inflammation, micro tears can occur in the plantar fascia, and that just causes a chronic inflammation. Typically, that's almost always treated conservatively. Usually, it may involve activity modification, something to take the pressure off that area. Stretching, although in some cases, or in most cases with dancers, that may not be the underlying issue, because they're often, the range of motion is good. It may just take time for that area to heal in. You can rupture the plantar fascia too, which is basically, when the area is so inflamed, it just weakens to the point where it tears. That is not a bad thing, although it does limit activity for a while, but oftentimes then the plantar fascia will heal, and you typically don't have any problem with fasciitis after that. Certainly don't want it to get to that point where it ruptures, but if that's the case, it's often because it's ignored for so long that it'll just tear because you didn't come in to get it looked at, or they just were dancing through it. So it's not detrimental to the point where it'll ruin somebody's career, but it's certainly a concern. The thing that the most concerning is when you have a calcaneal stress fracture, which looks like a hairline fracture in the heel that can occur. That's, again, just like any stress fracture from repetitive overload, it can affect the way the heel, hits, when it hits the ground multiple times, it's definitely a concern. Bursitis is another problem. Baxter's nerve, I think, is a little esoteric, but it's one of the nerve branches off of the nerve in the foot that is directly in line with this area. So right on the bottom of the heel, it can get irritated or pinched, and you would have some burning pain there. You wouldn't know. It would be hard to diagnose that in the nurse's office, but it would be something that we would look at a little bit more closely. I just have some other pictures of. So this is a calcaneal stress fracture, and this is off of an MRI. Basically, the heel bone is here, this entire thing. The Achilles tendon here, the ankle and foot. But you can appreciate normal bone looks like this, but on this particular area, there's a lot of white coloration here, and it's the edema, and then you can appreciate the arrow pointing to the crack in the bone. You may not even see that on an x-ray. So that's differentiated exam-wise by pain generalized around the heel. And you can do a test, I call it the compression test, where you actually cup the heel in your hands and push with your palms directly on both sides of the heel bone. And if that generates significant pain, then I'm more concerned about a stress fracture than I am any other thing like plantar fasciitis or even Achilles tendonitis, because that's usually point tender right over the tendon. So you're pushing right on the tendon area or on the bottom of the heel. But when you squeeze the heel, typically those people don't have pain. They may have a stress fracture if they do. Okay, so that's important to look at. And then just another little picture about the bursa on the bottom of the foot. That's something that you can have. It's hard to differentiate between that and plantar fasciitis, but more concerning is the stress fracture. And finally, I put up the final slide here is just basically shin splints versus stress fractures of the tibia. Shin splints are not as concerning, but you should know that they exist. I think everybody knows, you know, or has heard shin splint before. But basically, what it is, it's the inflammation of the muscle lining as it attaches to the bone. So that, you know, area in the front of the bone, in the front of the shin, the anterior compartment of the front compartment of muscles that help you pull your foot and your toes up, that's where that is. And that lining can sometimes get inflamed from overuse and repetitive use, and it hurts right in the front of the tibia bone. So you push on the front of the muscle in the bone and it hurts there. More commonly in the back or on the inside of the foot or of the tibia, you feel pain, and it's common in runners, and it can occur in dancers. But now the back musculature gets inflamed right where it attaches to the bone, and it's typically on the back of the leg, usually in these areas, sort of towards the bottom around the ankle on the inside. So that's a condition that is almost always managed conservatively, and it involves, you know, usually activity modification, some therapy, stretching, and modalities that can get the inflammation down. But if it's ignored, it can go on to something like this, which is now a stress fracture. So I know I wrote about it in the article in the magazine this quarter, but you shouldn't ignore this type of pain. I mean, because it can definitely cause a stress fracture, because now the inflammation's in the bone and it can cause it to crack. So when you have a stress fracture, it doesn't mean you need surgery. It just means you have a fracture, and that takes weeks to heal, as opposed to maybe a week or two of some modalities or therapy.
So you're saying that the shin splints, if they're ignored and they repeatedly do their running, do their dancing, do their everything that they should be doing, it will go eventually to
More
stress
than likely go on to stress fracture. I wouldn't put 100% guarantee on it, but it's highly likely that it will. And I've seen a number of athletes that ignore it, track runners and other high level, that come in with a stress fracture that it's, you know, sometimes hard to diagnose, sometimes easy. You see it right on the x-ray. So that's just a little bit of an overview of those conditions. I thought, you know, would be good to talk about. You know, like I said, the majority of these things you can treat conservatively, and that's good, because then I send them to my friend Mark, and he tells me everything that I missed and makes people better. So I'll give it up to Mark a little bit just to let him touch on, you know, what he sees or how he approaches the dancer specifically, and as it relates to athletics and what things he looks at. So thanks, Mark.
I got a question for you still.
Okay. I'm here.
Most times they'll go in, they'll see a variety of specialists, whether it's their family doctor or a regular orthopedic or the specialist, the sports medicine and the foot doctor. Most of them start with the exam, then the x-ray. Then some of them go into an MRI. And the parents question, like, oh, they just had this done or that done. I didn't hear MRI much out of anything that you were talking about. Is that an overkill? Is that...
No, and you know, I didn't get into diagnostics too much because, I mean, you saw some various x-rays and MRIs here, but I mean, from my standpoint, that goes along with the diagnostic workup. A lot of the conditions I'm comfortable clinically examining and sort of getting an idea of what it is, but typically there is an x-ray involved, and if they have an x-ray, they should bring it in, obviously. And if a lot of times I'll see substandard x-rays or something that doesn't show me what I need to look at, so I can get an x-ray in the office if it's appropriate. And then depending on what exactly I think is going on, a better diagnostic tool may need to be used. So whether that's an MRI or a CAT scan or a bone scan, an ultrasound can also be done. So these are all non-invasive things typically. I sort of tailor what I need based on what their symptoms are. And you know, if it's just an x-ray, then that's all I'll use, you know. So that's sort of my approach.
Because some of the parents, you know, that may be why they don't go, because they are between insurances or something, MRIs. You don't mind the x-rays, but once they pull out that MRI, that's where the cost comes in.
I know. And if your deductible hasn't been met and it's early in the year, I mean, I understand all that, and I definitely would try to work with patients, and I don't insist on anything. So if it's something I think is safe to proceed without an MRI, then we'll do it. The only thing that they have to understand then is since I'm conservative, I might treat it like it's the worst possible thing they have, and they may not like to hear how I'm going to treat it, because if I don't know if it's a fracture, I'm going to treat it like a fracture because I don't want them to hurt themselves even more, and that involves casting sometimes, and a boot, which would limit their activity at that point. So those are some things I talk about with them. I don't expect them to do anything. I just have to tell them how it is, and I don't want to risk their safety.
I've heard also from the different ones that they can't make the diagnosis, and it continues, then they resort to the MRI just to make sure something else isn't working.
Yeah.
And somebody from probably about 9 to 10 years ago, I won't say because you have it filmed, they had said the dancers, they don't like to cast dancers. Is that a common practice for most?
I don't know what other people do, but I think my philosophy, and I've talked about this with Mark too, is you have to get rid of whatever the inflammation is, or if it's a fracture, that has to resolve before you can effectively do anything with anybody. So I am not opposed to casting dancers. If it can be done for a short amount of time or shorter than usual, then I'll do it. But I'm not opposed to doing that because I feel like they'll be able to get back whatever they lose based on the casting.
That's the thing, is losing that.
Yeah, and that can certainly happen.
Whereas they'll put them in a boot versus because the recovery is faster than actual casting.
Right. Well, I can't make a person heal faster. I can certainly make them heal slower if I'm putting it at risk. Then if they're doing things that they shouldn't be doing, or a lot of people don't. They may wear the boot out of the office, but I can't guarantee that they're going to wear it the next day. So sometimes a cast is better because it's on 24 hours a day, 7 days a week, and you get them back and they're torn up and beat up, but they're still working. That's what matters, and I think mentally, when you tell them this is going to make you better, it may not make you better faster, but it's going to help you better than a boot sometimes, depending on the injury. When we get these injuries, we're looking to treat what the problem is. We're working on local treatment of the injury, but also too, I think we have the obligation when you're working with higher level performers, like gymnasts, like skaters, like dancers. I've had the luxury, and it's very fun to work with these people because they do things that the average person can't do. So you have to be a little bit, you have to think, out of the box, in the clinic, with your exam, with your evaluation, and then, the goals and the standards you're setting for, for this person, this client, the patient. So when I see, something either as minor or major as it may be, my exam doesn't change. I'm always going to look at everything, and I think, and it's because you have to. So in someone who dances, we're going to look at, the foot and ankle, if it's, so in terms of treating a condition at the foot and ankle, I'm going to look to see, are the ranges of motion, are they adequate? Is there any motion that might be a little bit too much? So I'm going to look at joint function, range of motion, looking at muscle performance in terms of generating force, and also slowing down and controlling force, because when you're talking about leaps and jumps and assuming, coming into a position, something just like a plie, the muscles are working differently than producing force for a jump. And so I want to look at how well the person can, generate force and control it both ways. So muscles lengthen and shorten to do the things required for dance. And I need to know how well or how poorly they do that. So
first off, when I think of the dancer, the range of motion, I actually went online last night to look at some of the poses and positions to kind of freshen, so I wouldn't sound, yeah. But it's amazing at what the hips have to do. So in terms of the amount, the rotation, the flexibility, in all planes. So I'll of course check that. And usually, you know, the flexibility of musculature is more than adequate, usually. If it's not, we address it. That's very simple. But sometimes the joint can be a problem. The hip joint might not work well. You could have, you know, an impingement in the hip. You can have a tight capsule of the hip. So, you know, looking at these things. Because that poor hip motion, poor joint function, and poor strength and muscle imbalance can certainly influence everything below, which can, you know, be a contributing cause or even a major cause of some of these foot and ankle problems. So, so when I assess these, you know, these patients, you know, and I'm testing the muscles of the hip, and I'm expecting them to hurl me to the ceiling, and I'm breaking their muscle test fairly easily. It's actually, and you know, high level, you know, from volleyball players to track to gymnasts, skaters, dancers. And so I think, you know, the assumption that Dr. Sauer said before, the assumption is that because this person functions at a very high level, that their whole kinetic engine works well. And it doesn't always work well. And so, so there's special, you know, there's some pretty easy tests to check, you know, deep core muscle function, the deep abdominals, the deep low back muscles, which help stabilize the lumbar and pelvic complex. Because if you need stability here, for the legs to move below them. So I spend a lot of time checking this stuff. Even though they might come in with from an ankle sprain because of a missed landing, you know, there's a whole bunch of, and we're going to rehab that sprain from the perineals and addressing inflammation and restoring joint mobility, strength and balance, you know, and maybe getting in, and of course getting back to sport specific or dance specific things. You know, I like to look at all this other stuff, and often I found, as you know, I think more effective clinicians change, you know, and since I've addressed a lot of these things over time, gotten better at doing it, you know, the patient outcomes are much better, and then you're preventing further injury down the line. So, you know, the one slide which addressed ground reaction force. It's massive amounts of force being transmitted through a person's body in landing. You know, 5-6 times. I think in the runner's talk we did, it can sometimes with plyometric training, which is kind of like jumping, you know, it can be up to 12 times, 12 times as much. I don't care if you have this teeny little person, you know, 12 times, that's a ton of force. So muscle function, you know, muscle function is a really big shock absorber. And so what I need to know, can they produce it, and can they absorb, can they attenuate shock from the foot and ankle, through the leg, through the thigh, and up into the hip and pelvic complex. So the other thing that I always let, you know, anyone who does any sport specific thing, and when I say sport specific, I'm of course you know, including dance, because you know you get parents involved and concerned, and sometimes, you know, so you'll not that I've gotten them, but calls from, you know, a coach or someone at the studio. When you're talking about a high level performer, I always say I am not the expert in what you do. You know, your teacher is, your coach is. That's not our job. You know, so our job is to be the expert at why you're sitting in front of me. So so that's something, you know, I think it is, you have to be relevant to the person you're treating and know their craft. So I always spend time, you know, making sure I know to address the specific things that they need to get back to. But just I'm always letting them know that, you know, we'll work on sport, you know, these real specific things, you know, for dance. However, you know, our job is to get you to return to get back to having fun, to do what you do well, to set you up to do well, you know, back in the studio, and to ramp back to that safely. So. So that's really the other part that I think sometimes when people go through a rehab process, you know, the coaches or the teachers sometimes might feel left out, but I make sure that's loud and clear, and I try to communicate that to them, especially when the athlete is cleared, when Dr. Sauer gives me the okay, to say, all right, let's start doing, dance-specific or sport-specific training, that's communicated to the coach or to the studio teacher or whoever I need to, if we need to speak to them, get them involved so that they know some of the restrictions or some of the things that the patient can start doing safely. So it's so that's what I try to look at, pretty much top to bottom. So, any questions? Please.
When you rehab the dancers, do you focus on parallel or do you go into turnout with them at all?
That's it. When we get to the dance specific things, it depends on. That's a very specific question. I think I would make sure that they can do the things that they are needed to do. I'm not quite sure what the question is geared to. Is there some controversy of parallel versus turnout or some type of?
I mean, I just in general, I mean, I'm an athletic trainer.
Okay.
I do work with the dancers.
Sure.
And it's more of an acute care situation.
Okay.
However, when they stretch or when you strength test them, do you test them also, I guess, more of the question, in turnout, in addition to parallel? Or do you focus more of your job in parallel and leave the turnout training to the studio itself?
There was actually the one thing that I do on top of not just being a PT, but I'm a practitioner of Pilates for rehabilitation, and that's something I earned that in 2005, and so using the Pilates equipment helps to create a beautiful environment for not only to assist someone who has impairment, but also to, when you need to apply force, to work them against things. So it's a nice environment to, so you can do, like say on the reformer, you can have them do like with feet and straps, all kinds of things, in turnout or parallel. Really, I try to address the demands of the person in front of me. And if they're not ready, I do not believe on rehabbing someone into pain. I think that is their whole reason for coming was because of that. I think good rehab, yes, there's some bumps in the road sometimes, but but I think maybe if a condition of pain was in turnout, well then we gradually get there. I don't believe in if to test them in turnout if turnout was painful. That doesn't make sense to me. I try to do a very commonsensical approach. You can muscle test. I can get the picture of muscle function from gross testing, classical muscle testing. But I think, and you can get a good idea of what they can generate or not generate, or working concentrically or eccentrically from that. And I think you can extrapolate with experience on how to implement that into the rehab plan.